96% of Medco pharmacy dollars go to chronic disease care also, and 25% of that are for children, which is an enlightenment. And that is, again, diabetes and asthma. So these, if you can get control of the chronic, which is primarily diabetes and asthma, you're getting a lot more adult asthma also. Then, and you can control those costs by managing the care, then you bring those costs down. But as was pointed out to me this morning by a doctor, the longer we live, because we're getting to make you live longer because we're doing preventive care and other things, no matter what zero you reach along the way, you're going to have healthcare issues because you're aging. And we'll have to pay for those. So when you get to the very end, then you have to discuss with the families what measures do you want to take for the person that's at the end, and what measures does that person want. Some people don't want any. Some people want, give me everything you possibly can for as long as you can. And that's a debate that will probably go on for a long time, because who makes the decision? In Europe, they do. In places where they have, socialized medicine, they do make those decisions. That if you're 80, you don't get a hip replacement. Here we do, and you can live to 90. You're going to have science, and it's going to take a long time, because particularly Americans like to go to the doctors they want to go to. And if you put them in an ACO, and you say to them, this is where you're going to get your care. And Caritas is a great example. They're going to have they're a natural ACO, where you can stay in the system. And if you go out of that system for specialty or something else, you're going to have to pay more. Accountable care organization, that's again the future. Global payments and these care organizations. An example of one of them is a group of docs on the Cape decided they'll form an ACO. And they'll do global payments with Tufts, or I think it was Tufts. So sounds great. They keep the costs down. They're getting a better bang for their buck on any MRIs or CAT scans they want to order, because they're not going to Cape Cod Hospital for those where it's higher. Where it's higher, they're going to, say, a Shields or another off-campus place that will lower the cost for them because of the volume. They're giving them their volume, again, market share. And the problem is, though, they're not using Cape Cod Hospital for their patient care either. If they present there, they're being told to send them to BI, where they have the ACO contract. So you're cutting out the one healthcare institution in the Cape that's there to provide, that needs to be there 24/7, and has to have all kinds of other extra beds in case of public health emergencies, things that the Department of Public Health and the state and federal government make them have, that ambulatory surgery centers and MRI centers don't have to do. So you constantly have these other bleeders coming off the system, which is why hospitals are getting more and more fragile in their economies. Yeah, we've been consistently assisting Quincy.
Yeah, I know.
We forgave them a $12 million debt, and we have been giving them money through, what is it, the Essential Community Provider Fund that we set up. And we don't want them to close. They have a locked behavioral health unit that's extremely important to the health care for the whole region. That's a lost leader, and we know that. Medicaid does not pay. We don't pay for Medicaid $1 for the dollar, and Medicare doesn't pay. So you have these lost leaders out there, but you don't want to lose them. It's like when Kearney was in danger of closing. We didn't want to lose Kearney because the volume going into the emergency rooms in the other Boston hospitals wouldn't be able to handle it. So you want to hold on to places that need to be there. And how we do that, and how we do the payment mixes, and how we keep it. I mean, it's just, this is a constant struggle. And it'd be nice if we had a healthcare czar that said, this is how you do it, and that czar had the authority to say, this is how everyone's going to play. But
it's challenging.
It's more than challenging. And again, they're major employers. So you don't want them to go away, because they employ large numbers of people, and they employ, particularly hospitals, employ people who don't work other places, who have maybe high-end disabilities, but they can still work. and they can still be beneficial members of society and feel like they're plugged in.
Is there anything, though, that is on the state legislative or executive levels beyond what has already been done that can help save Quincy Medical at this point? I mean, what can be done?
You look at all of them, and the management was different, and they used development money for operating. Development money should be always kept for other things, like building, like South Shore has been very successful with that. But the old models don't work, so you really need good management people in there that understand. And one other thing we're trying to do also, and it's certainly not going to save Quincy or anybody else, is by having a uniform billing and a coding system, and we've mandated that happen by the end of 2012, we'll save $1 billion over 10 years. And you'll save doctors' time and hospital time filling out those forms or having to send them back because the payer said you punched the wrong code, or we're not paying because somebody did something wrong on the form. So it'll all be the same, and that will cut down. And electronic records and electronic prescriptions will not only be more efficient and cut down costs on the prescription pads, electronic prescription pads, you'll cut down on doctor shopping for drugs. So there are a lot of things in the mix that are going to cost us up front. We got some very good federal money for that. We are way ahead of the other states again on that because we set that up in our 2008 bill. We were ready to roll when the money came out, and we had matching money, so we are in the process of doing that and giving doctors grants for their own offices to do that, and the big hospitals are already there, and the smaller hospitals, we have the money to assist them through MTC. So there's lots of moving pieces here, but we've had our eye on Quincy, and we'll continue to keep our eye on Quincy and a couple of other hospitals that are niche type hospitals that are in that same.
Anything that you can say is going to happen this week or next in terms of advancing this to the next step?
When do you think we'll?
We'd love to move as quickly as
We'd
possible.
love to get it out Thursday, but it's the devil is in the details.
Mm-hmm.
And every time we try to think the details are done, something else pops up.
Or
I think
resistance?
overall this is so involved and only a couple of members are really on top of it. Now when it comes out, there'll be absolutely interest by all the members. They all want to lower the cost for businesses, so there'll be an interest there, but that will be a competing interest by whoever it is feels that they might be affected in a negative way. And they will go to them and say, oh, you have to file this amendment or that amendment. And those are the things that we're trying hard not to have happen on a large scale, so that by telling them we will be doing the second piece. But we met with the regional HHS person yesterday. She was just appointed, what, 2 weeks ago?